really wonderful resource to us. We're just getting to know each other. He's a physician assistant in the Division of Hospital Medicine at Dell Medical Center and also leads several quality and process improvement projects. Mr. Bottner leads the B team, a full-service consultation team that provides patients with opioid use disorder medication-assisted treatments while hospitalized and links them with appropriate outpatient care. So this is while they're in the hospital. He's going to tell you more about this. And leads efforts to improve electrolyte replacement protocols, readmission prevention, and continuity of care after hospital discharge. And it's just wonderful to see what they're doing in Austin. He's going to tell us a little bit about what we might be able to do in San Antonio. Thank you so much. And please, let's introduce and give him a warm welcome. Thank you.
Thank you.
Would we need the clicker?
Yep, got it. Thank you. All right, hello. Thank you so much for having me. I need to change that. It's going to be opioid use disorder pharmacotherapy after today.
I was stumbling too with my language, but I was all in at that point. So I was just, yeah.
So thank you so much for having me. And this is a really good sort of natural progression to talk about the emergency department and the role that ERs play. And I think Dr. Martin did an outstanding job doing that. And to sort of transition now into what happens for the patients who have an opioid use disorder, who don't stay in the emergency department and they don't leave the emergency department, they go to the floor, they get admitted to the hospital. And what sort of services and what sort of treatment and what sort of stigma reduction do we want to do within the walls of our hospital outside of the emergency department? And I will sort of start this with a confession. And the confession is that if you had asked me a year and a half ago if I would be leading a addiction-related effort in my hospital, I probably would have laughed. And that a year ago or a year and a half ago, I was part of the problem. So I've been in healthcare for about 10 years, 5 years as a PA. Before that, I was a police officer, an EMT, a firefighter, and a dispatcher. And so these guys know, like, I had an identity crisis for a while. And so when I went to PA school, I had sort of my preconceived notions that I picked up in the field. And the medical training system, whether it's medical school, PA school, advanced practice, nursing school, none of those institutions historically have taught addiction. So I graduated PA school about 4.5 years ago, and we did not teach addiction in my program. That's changing. But I came to this job with really my own preconceived biases, without having any tools in my tool belt, without any formal training in how to have conversations around addiction with my patients or my peers. And so when I got to the hospital and a patient got admitted from the ER with an endocarditis or a spinal abscess, I was treating that. I knew exactly how to treat endocarditis, exactly how to treat spinal abscess. That's what I was trained to do. But we really weren't treating the underlying problem, the underlying illness, which was the opioid addiction, the opioid use disorder. And about a year and a half ago, I started to recognize that what we were doing was essentially treating these medical problems, sending patients back into the community with completely the inappropriate or inadequate or oftentimes absent resources to support them into recovery, ultimately only to see the same patients again. And so I know Dr. Martin's heard this term before, but the whole idea of frequent flyers, right? Folks who come back to the ER, folks who come back to the inpatient wards frequently for sort of the same types of problems. And in the hospital setting, in the inpatient setting in particular, we worry a lot about readmission. We worry a lot about patients who are discharged against medical advice. We worry about length of stay. And these are all things that are very much dramatically impacted by opioid use disorder. And so about a year and a half ago, I kind of had a aha moment, and I sort of entered into this recovery of my own. And the recovery was really around stigma reduction of my own and learning, looking at the evidence, looking at the literature, seeing what was happening in my community and how we can make a difference within the walls of the hospital. And that's what led to the starting of the Buprenorphine team and ultimately the SHOUT program that I'll talk about in just a minute. And so there was a similar slide that in Dr. Martin's deck, and I have one of these as well. And so this is really sort of what I describe as the current state. So this is the current state of what happens to patients when they enter the hospital system in the vast majority of hospitals across the United States, right? The whole concept of detox, the whole concept of using things like clonidine and loperamide to help patients get over an opioid withdrawal, that's pretty basic science. We teach it to our medical students in probably about 30 minutes. It's pretty straightforward. It's pretty easy. Opioid withdrawal in and of itself is not as dangerous as, let's say, a benzodiazepine withdrawal or an alcohol withdrawal. And so these patients come in and we detox them, and we pat ourselves on the back because we think we've done something good because, opioid withdrawal is sort of this horrible experience, and now we've helped support them through that. So we've done a good thing as a medical community. And then we send the patients back out into the community, of course, only oftentimes to have these patients reappear in the ER and get admitted. And so at the vast majority of hospitals in the United States, this is what we do. We detox. And we detox, and we don't offer any sort of resources, any other sort of intervention. And the data is pretty clear that, in particular for patients who use heroin, that 80% of those patients within 30 days are back to using heroin again because we haven't provided them a support system. We haven't provided them means to enter recovery. We've gotten them through their most immediate sort of medical need, that withdrawal, and that's all that we've done. And I challenged myself and my colleagues to maybe do something a little bit different. And so I know the slide's a little bit busy, but this is essentially the case for why opioid agonist therapy is so important in general, but also important in particular for our hospital settings. And so we know that these medications help to reduce illicit drug use and injection use, increases completion of inpatient medical therapy. So in the hospital setting, the discharge against medical advice is one of the worst things to happen to a hospital. So this is a situation where a patient's admitted to the hospital, and for whatever reason, they leave the hospital before their care team decides that their treatment is done. And that has a lot of really negative implications for the institution. It has some negative implications for the staff. But most importantly, it has negative implications for that patient because whatever they're in the hospital for, whatever medical reason they're in the hospital for, they haven't completed that treatment. So we put them back in the community very, very much without the full treatment of what they were there for in the first place. And I'll tell you a story about how that kind of plays into all this in just a minute. Reduces HIV, HCV, bacterial bloodborne transmission of illness, increases abstinence, and again, the majority of patients will return to using if we don't use pharmacotherapy while those patients are in the hospital. And I think part of what has really shifted the conversation at our institution is that we're scientists, right? And we have this clinical training, and the conversation is often around morbidity and mortality, right? And that's important. It's extremely important. But I would also argue that equal, if not more important than that, is this whole patient-centered idea of like getting back to a life where you can have a stable job and have good relationship with your family members. Perhaps your child is in child services and you can get your child back, right? Those are like real things that are really tangible to our patients, and these treatments help with that. And as we build these systems of recovery within the hospital system, we can help facilitate that. Reduces readmission, reduces cost. I'll actually just skip over the emergency department one altogether because I think Dr. Martin did a really good job with that. For women's health, neonatal abstinence syndrome is probably one of the most alarming things happening as a whole. If I had to pick just one thing within the opioid epidemic, if you will. And so we know that these medications and that these approaches can really help pregnant patients in particular start on treatment while they're in the hospital and enter recovery. So when patients come into the hospital and they're admitted, they're often experiencing uncomfortable withdrawal, uncomfortable cravings. They're motivated for change, and they're away from their triggering environments, right? And so if we take patients out of a triggering environment and we put them in a supportive environment where oftentimes they're staying for days or weeks at a time. So a patient who gets admitted to our hospital who has a heart infection, endocarditis, or a spine infection like a spinal abscess, they're staying within our hospital on my service for 6 weeks of IV antibiotics. 6 weeks. So if we're not offering treatment, if we're not offering recovery opportunities for these patients in 6 weeks, that's crazy, right? But that's the standard of care at most institutions. And we know, this has been looked at, that 30% of patients will leave the hospital against medical advice. Any hospital practitioners? So usually I give these talks to hospitals. And when I ask if they've ever had a group of patients leave AMA because of not being treated appropriately in the hospital setting, every hand in the room goes up. Every hand in the room. And so you have a patient who has an infection of their heart, an extremely life-threatening medical condition, and they leave the hospital after 1 week or 2 weeks of antibiotics. And so that patient's now in the community with this devastating heart infection. that infection's going to get worse. They are going to come back to the hospital, right? And so imagine the impact on the healthcare system, right? The economics of that. But patients leave because they're having withdrawal that's not being treated. They have fear of being mistreated because they've been mistreated before. And they're having cravings that are not being appropriately addressed. And so these are things that we sought to really change and improve upon. This is the quadruple aim. And the quadruple aim is sort of how we are supposed to evaluate big healthcare problems. And if you have a healthcare problem with a solution that touches on all 4 of the quadruple aims, then you get like the gold star, right? And so the quadruple aim focuses on patient experience. It focuses on population health, reducing costs, and care team well-being. And for a long time, it was actually the triple aim. The quadruple aim is pretty new. It's only been around for a few years, and it focuses on provider well-being, on the medical team. And there is absolutely nothing that we're doing in healthcare right now that I think speaks to the quadruple aim more than creating opportunities for recovery when patients are hospitalized. And I think that you'll get a little more sense of that as I share the story of how we started. We talked before about readmission. So readmission is the holy grail of hospital medicine and hospital administration. It is so important to the hospital ecosystem, and in particular to our hospital administrators. And this was a study that came out very recently, it's the beginning of January, and this was just for opioid use disorder, just for having patients on buprenorphine, that they were able to reduce 30-day readmissions for opioid use disorder related reasons by 53% after 30 days and after 90 days, 43%. There is nothing, absolutely nothing else that happens in a hospital, I promise you, that reduces readmissions as much as actually paying attention to patients with opioid use disorder and providing appropriate care. This is a kind of an older slide, but one that I've used in all the talks I've given to our residents. We're an academic center, and really this was one of the cornerstones of helping to reduce stigma across the institution and helping our trainees understand that the way we talk about patients with opioid addiction, the way we talk with, not to, with patients who have opioid addiction is significantly different. And I had to really think about that because I was contributing to this problem up until about 1.5 years ago, and I realized that what we were doing was actually stigmatizing patients for relapse, right? For this whole concept of relapse. And that was actually really frustrating because when we looked at our safety net hospital, we had patients, right? The patient who has diabetes, who is non-adherent with their insulin, who comes back to the emergency department for the 4th time that month because they didn't want to take their insulin and now their blood glucose is 450 and they don't feel well and they get admitted to the medicine service. I guarantee you that that patient gets treated differently, or 1.5 years ago would have been treated differently than the patient who uses heroin and is back in the hospital with their 3rd spinal abscess or an ejection site abscess. And so really shifting the needle in how we talk and appreciating that that the underlying thing that we're treating is the opioid use disorder, and that opioid use disorder is a chronic, relapsing, remitting medical condition, right? It's not a psychiatric condition. It's a medical condition. And if I am being trained to deliver medical care, then I better treat it. I better figure out how to provide the most appropriate patient-centered care for that patient. So why the buprenorphine team? What is the buprenorphine team? This is the team that we started to sort of shift the needle on this. So we're an interprofessional, multidisciplinary group, and our job is to screen appropriate patients for buprenorphine induction, although I would probably change that now 6 months later to say that we screen patients for opioid use disorder. We assist in starting buprenorphine for patients while they're hospitalized. We provide linkage with an outpatient clinic. So we've developed exceptionally strong relationships with outpatient clinics, and we provide, it used to be called the warm handoff, then it was the hot handoff, now we call it the boiling hot handoff because we have such a close relationship with them. And I would say that when we started this work, really the goal was let's get buprenorphine out there. And now I would say that that's maybe 50% of it, and so much more is around reducing stigma and teaching as much as we can throughout the institution on appropriate care for this patient population. So this is our team. That's the B team. So we have Evan, who's a chaplain, Ken's a nurse, Kirsten's a pharmacist, Clarissa is a hospital medicine physician, Rachel's a social worker. Elise is an advanced practice nurse with our palliative care service. Blair is our chief of psychiatry. Amber's a medical student. Chris is a hospital medicine physician and a national expert on healthcare value, actually wrote the book on healthcare value. That's myself as a PA, and Nick Christian, who's an internal medicine resident. And so we take a ton of pride and joy out of the interprofessional, multidisciplinary effort that we bring to this work. And Chris actually sort of describes our team as a football team, that if any one of us stopped doing the work that we're doing, the whole team would fall apart. So every single person that you see on the screen right now plays an incredibly pivotal role in the success that we've had. And so I wanted to give you just a snapshot of some data, and then we'll talk a little bit about kind of how we did it and what the next steps are. So this data goes from the middle of September until the end of December 2018. So it's not a very long period of time. And it is only a reflection of patients who are admitted to our 200-bed academic hospital in downtown Austin. It does not include patients in the ER, and it does not include pregnant patients. They automatically get transferred to another hospital about a mile up the road. We don't have obstetric services at our hospital. So with that in mind, we had 38 referrals for services in about 3 months. And these were patients who about 13 of which were eligible for buprenorphine, and all 13 were started. It's a really important distinction about this. When we first started doing this work about a year ago, we built a partnership with several of the clinics, but the main clinic that we were going to refer patients to was also just about starting up as well. And they had a whole list of eligibility criteria for patients. And so we adopted their eligibility criteria. And as you can see, that made a lot of patients ineligible for services. Well, about a year ago, which was when we first started having these discussions, myself and the director of that clinic gave a talk at the Texas Society of Addiction Medicine, and he had a slide up that had all of these eligibility criteria. 2 weeks ago, we gave the same talk at the same meeting, and he had the same slide, except that whole list of eligibility criteria, there were only 2 left. And what he described was what we were seeing ourselves, and we were independently, yet simultaneously figuring out that all we were doing was creating barriers to recovery. And that if you were a patient who had an opioid use disorder, you should get service. No matter, even if you do not want buprenorphine, we should come up with something else. We should be linking you with other things in the community. And so that's what we've started doing now. So if you look at our data that goes beyond, so January on, it's changed a lot. So now every patient that gets referred to us gets some sort of service. Every single patient gets a resource packet that describes all sorts of resources in the community. Everything from peer recovery resources, which by the way, we are in the process of bringing peer recovery into the hospital, which will be hopefully a talk we'll give next year, all the way to naloxone prescription. So all of this is happening, which is why this looks a little bit misleading. So what's important about this though is providing buprenorphine in the hospital is helpful for controlling cravings. It's helpful for controlling withdrawal. And so for some patients, we start them on buprenorphine just so that they'll complete their 6-week course of antibiotics for, let's say, endocarditis. And when they leave the hospital, we taper it because they don't want to be on it in the community, and we certainly don't force patients to do that. We still refer them to clinic resources, and we just don't continue the medication. But ideally, we would get patients plugged into a clinic and have them continue therapy when they leave the hospital. And so 70% follow up with the clinic at 1 week, 50% are still engaged at 1 month, and we don't have our 6 month or our 3 month data quite yet. The 3 month data actually we just came out, it's about 30%. And what's important about this is that we are an institution that does not have an addiction medicine service. I would love if we had an addiction medicine service, but we don't. And there are virtually no programs in the literature that talk about starting pharmacotherapy for OUD while patients are hospitalized on inpatient wards. And the programs that are described in the literature are at extremely large academic institutions where they have addiction medicine programs and addiction medicine fellowships. And the patients, when they're seen in the hospital by an addictionologist, it's that same addictionologist who sees the patient when they leave the hospital or one of their colleagues at a clinic which is typically owned by that same healthcare system. So the conversation within the electronic health record is very seamless. We don't have that. We have none of that, right? And so our goal and our vision was, the ask that we had of ourselves was, can we train internists and surgeons and family medicine practitioners and nurses and pharmacists and social workers to screen OUD and start the recovery process in the hospital and escalate really complex care to addictionologists and psychiatrists kind of as needed, knowing that community it's just not large enough to take care of all of the patients who need help. So can I train my colleagues to do some of this, to at least start that process? And so the data you're seeing on the screen now, it's just the beginning, but this is data that is equal to the institutions that have formal addiction medicine programs. And this is the only program in the entire state of Texas doing this right now. So if we can take this, we can get it to work really well, and then we can bring it to every of the 600 plus hospitals across the state of Texas. Imagine all the good that we can do. So this is the story of our very first patient that we provided buprenorphine to in the hospital. It's a 42-year-old African-American guy from Austin, grew up on the east side, third generation in our city. History of OUD, and actually describes himself as being sort of a hustler, right? So his parents took him out of school when he was 12 years old so that he could sell marijuana, eventually selling crack. And the purpose of all of this was to fund his parents' substance use. And so he went through this for years and years until he was about 18 years old. He got caught with a ton of crack, not an actual ton, a lot. And that began his sort of cycle of being in and out of incarceration. And this was a guy who never knew violence, he never fought, but now he entered the jail system and he kind of learned how to fight out of survival, spent a lot of time in solitary confinement, which is where he learned how to draw. And he would describe how he had 10 nieces and nephews and they all looked up to him. He was their role model and they wanted to emulate everything he did. And I met him when he was admitted for his third episode of endocarditis. So this patient had spent 4 weeks in the hospital, 2 separate admissions, 2 weeks each, so 4 weeks total, which you might argue was wasted time from a healthcare system standpoint and extremely dangerous for this patient. And when I asked him why he left the 2 times previously, it was because he said he wasn't getting good care because we weren't talking to him like he was a human and we weren't treating his withdrawals and his cravings. So now he's admitted for a 3rd time, same things happening again. This is right around the time that we're talking about starting our program, but we hadn't actually started it yet, but people sort of had heard bits and pieces about it. He sneaks out of the hospital and uses heroin on the street. Comes back into the hospital, his nurse notices he's acting a little odd, does a drug screen, comes back positive, calls administration. Administration's furious. Discharge AMA, right? Unlike the previous 2 AMA discharges that were on his part, this was now going to be an administrative discharge against medical advice. You're in our hospital, you're not following our rules, we warned you about this, out you go. And so his nurse, who had heard a little bit about what we were trying to do, called me and said, is there anything at all that you could do? I said, let me see. So I called our chief medical officer and I said, if I can convince him to try this medicine, if I can convince him to sort of calm down, because at this point he was extremely upset, will you give him another chance? And CMO was extremely reluctant, finally said yes. I said, okay, this is our moment. Hopefully this works. And I went to go see him, and he was so agitated, so upset, so disappointed, tearful, angry. He was throwing things, and it wasn't because he just wanted to act out. It was because he was frustrated that in the several decades plus, that he had been dealing with this, that this seemed to be the pattern that he always seemed to get himself into, and that nobody understood what he was going through. So I sat with him, we had a whole conversation, and sort of long story short, we started him on therapy. This was about 7 or 8 days into his hospitalization. He stayed the entire 6 weeks once we started his therapy. And the day after we started it, I came back to the hospital to kind of check on him, and I heard Led Zeppelin blasting down the hallway. And when I went to go see where it was coming from his room. And he brought a big stereo in, and he was dancing around the room. He was looking out, it was a big sunny day. He was looking out the window, talking about all the people on the street. Started talking about how he wanted to get an apartment when he left. He wanted to sort of work things out with his fiance. He wanted to get his kids back. He wanted to get a job. This was a different person 1 day later. 6 weeks later, even more so. And so before he left, he said, I want to draw you a picture. So I gave him paper and I said, draw me 2 pictures. One from before you kind of met our team and we trained your nurses and we started you on the buprenorphine and one after. And he took that instruction into one. And what's really cool about this picture, I'm actually really happy he did the one. So on the bottom right, trying to, from your perspective, okay, so bottom left is him. And he's on the street corner of East 3rd Street, which East 3rd Street, when this gentleman was growing up, was a time in Austin where East 3rd Street was not exactly a good place to be. And he's in despair, he's distraught. And as you go counterclockwise, he drew the mask because he'd said that you never really know when you buy these drugs on the street, you never truly know what you're getting. And so it's sort of the mask of addiction because you never know the kind of person that you're going to be. And you roll the die because you never know that this could be your last time using because you don't know what your drugs are mixed with. And he knew that. He's very articulate, very educated gentleman. And he says, I've been doing this for 20 years and my time has just been ticking away, which is where the stopwatch comes into. But then he says, through my darkness of addiction, the light, the brightness is meeting you and your team and being started on buprenorphine and being treated like a human being in this hospital, which is something I have never been treated like before in the entire time that I've had this problem. It's very compelling. So fast forward about 6 months, this was Assistant Secretary Cuvier, who is the guy at HHS who really leads all of the opioid efforts. So at the federal level, he is sort of the guy. And he came to Dell Med and he tweeted this out. And I share this with you because this is a gentleman who goes across the country and gives lectures and has his finger on the pulse of what's happening. And he thought that what we were doing was pretty novel. And I would argue that it is in the sense that there's not many hospitals in the nation doing this. And part of why I'm here today and I go around talking about this is because I think other hospitals need to do this too. This was an article, and you can Google this. It'll come up pretty quick because it just came out earlier this week. But the Statesman, which is sort of the main paper in Austin, did a whole story about the program a few weeks ago. This last week. So lessons learned. So this is sort of like the really important stuff. So number one, we grew the program organically from the bottom up. So this was not an executive level program where the CEO said, you shall all start treating patients nicely. No, it wasn't like that. This was a program that we grew from the bottom up by getting support from people who work at the bedside. Now that's not to say that executive support wasn't important. This is Dr. Tom Cavan. He was our chief medical officer for 16 years, which I'm told is very uncommon for a CMO to last that long. Really beloved CMO. And I went to him and I said, I think we have a problem here. I'd like your permission to work on it and sort of use your name to get buy-in when I need it. And he immediately said yes. And so having the executive support was hugely important, but it's not how we accomplished this. We accomplished it first by doing process mapping, by really looking at our institution and trying to figure out where are the breakdowns that are preventing this work from happening. So if a patient comes in from Dr. Martin's service in the ER and I'm admitting them, what's preventing me right now from identifying that patient as someone who's suffering from OUD and providing appropriate resources for recovery, which may include buprenorphine therapy? And how do we fix that? And for those who haven't done process mapping, I'm not a process map guru. We had some help doing this, but all of the different shapes and colors, they all have different meanings for different actions that happen throughout this. And hospitals are extremely process-driven places, and everything we do is a process. And you actually only need to do this once because the process, if you do it right, ends up being ingrained as part of the culture. So now at our hospital, it's part of the culture that if you're admitted and you have an OUD or we think you have an OUD, we are going to do the right thing. We are going to get you resources. So we don't even look at the process map anymore. But this was a really important team building exercise in the beginning. We went to the nurse education fair. Any nurses? Nurses? No nurses, really? I'll tell you that the way you make things happen in the hospital or probably in healthcare anywhere is you get nurse support, right? And so we did that. We have a nurse on our team. You saw Ken. Do not let the science fair-esque look of this board make you think it wasn't effective. So every single nurse at our institution has to go to the nurse education fair. They came to this program. They learned all about what we were doing, and that created the buzz. Shortly thereafter, I made a blog post for the Society of Hospital Medicine telling the story of our patient. And I purposely did this so that I could share it with the people that worked in our hospital. So this was one of the main things on our hospital intranet, and it sort of went viral within our hospital, and people were reading about the success story of treating that patient for 6 weeks in the hospital. And we started shifting the conversation. Now, it wasn't, when nurses got the phone call from the ER nurse with sign out, oh, I'm being cut off. It wasn't anymore about like how do we not take that patient who has a heroin use disorder. Now they're saying let's take that patient on our unit. All right, so I'm just going to fast forward a lot here. So many things to talk about still. Okay, so I guess in brief, I'll just say this. So this is the hospital, this is the medical school, and the goal now is to do this shout work, support hospital opioid use treatment, to take what we've done at our institution and to bring it to as many hospitals as we can across the state of Texas. I guess I will tell you to do this. So email me and I'll send you the rest of the slides because I think the work that we're doing, I think one of the main things that we've really been able to do is shift the needle and shift the standard of care. So no longer do patients come through the hospital with an OUD and they don't get appropriate treatment, they don't get appropriate recovery, patient-centered language. So I guess I won't take questions, but yeah, reach out and I'll be happy to share your slides and I'll be here the rest of the day as well. Thanks.
Sorry, I'm a plain-spoken person, so I apologize for the body language there. I think we have time we're going to do a naloxone training super quickly, but I just want to, if anyone has a couple burning questions that they wanted to ask Rich, I didn't mean to be so abrupt. Yes, ma'am.
While these patients are in your facility long-term on buprenorphine, are you performing serial urine drug testing?
Don't do it by default. If patients leave the unit and there's suspicion behaviorally that perhaps they used another substance, then we often will. It's up to the discretion of the care team, but they often will. But it's not standard, no.
So does the system set up there at Dell wait until the third day they're admitted and they start going through withdrawal to identify them, or is there a fairly accurate way to screen people up front, or do you actually do blood screens up front to see whether or not they have some kind of a substance use disorder, whether they're strung out on barbiturates or alcohol or whatever it is?
So the question is, how do we screen patients and when do we start therapy? We are in the process now, and it will be active within the next 3 months. Every single patient who gets admitted to the hospital will automatically be screened by nursing for an OUD, and that will help to screen patients and notify our team. Currently, we don't do that, and so typically we get the referral the next day after admission, and at that point, patients are actively withdrawing, which is actually what you want to start buprenorphine therapy. Mild withdrawal, not severe withdrawal. So.
Okay, so we're going to transition. Thank you so much.